Thank you very much, everyone, for coming to our Innovative Discovery Series seminar. We are delighted today to have Dr. Goldstein as our speaker for this ID series. So before introducing Dr. Goldstein, I'll take a few minutes to remind everyone of a few housekeeping items. Please make sure you sign in. Please RSVP so that we can better prepare for the next session, meaning food. Online participants, please keep mics muted unless asking a question and keep video turned off. Use the chat feature in BlueJeans if you have technical questions. And the next seminar will be what can be done about the cost of care for chronic diseases and conditions by Dr. Stanhope on January 22nd. That will be in room 1E80. And then we'll have cognitive assessments and aging physicians. Are patients or doctors the ones at risk by Dr. Ellison on February 5th.
Second floor, cath lab, theme floor, that. Respiratory, cath lab, second floor, theme floor, that.
So also we have the full schedule on the ACCEL website if you are interested, and all the previous presentations are available on our website, CTR, DE-CTR.org. So now I'm really very happy to introduce Dr. Goldstein here. Dr. Goldstein has a Master of Biomedical Informatics from Oregon Health Science University in Portland and a PhD in epidemiology from Drexel University that he got last September. He's currently a postdoctoral fellow in pediatrics and has accomplished a lot, actually. He wrote a book which is going to be published in December. And the title is Improving Population Health Using Electronic Health Records, Methods for Data Management and Epidemiological Analysis. And I think we should all read this book. He has multiple peer-reviewed articles. He's the associate editor of ClinfoWiki, which is a wiki, I'm not quite sure what a wiki is, but based out of Oregon Health Science University. And it's a site devoted to topics in clinical informatics. And he's also an active blogger with titles such as Assessing Exposure in Retrospective Cohorts, The Success of Epidemiology, The Why and When of Centering Continuous Predictors in Regression Modeling. And I think we are all going to get on your blog. It seems fascinating. So I'm really happy that you are here, and we look forward to your questions.
I was told I need to stand in front of this podium when I talk so everyone can hear me, because normally I like to run around a lot when I talk. So if you see me like gripping onto things here, it's just because I'm so excited about this. I'm glad that it looks like there's a great turnout today. So I hope everyone finds this to be as interesting as I think it is. The talk is going to be divided into two parts. The first part's going to be kind of a high-level overview, and then I'm going to get into the weeds a little bit, coming back at the end to a high-level overview. But the intention with the first part is to introduce the general concepts, and this is mainly just more of a theoretical discussion. And then the second part of the talk is an example of the methods in the work I'm doing with the neonatal intensive care unit. So for CME credits, there's some objectives to this talk: to understand EHR data for health research, to recognize appropriate study design, and grasp the analytic methods and understand the interpretation of the results. Before I begin, though, I wanted to take a survey, and can you just raise your hand if you have done research using data from health records before? And so that's pretty much everyone in the room. So keep your hands raised. And put your hand down if the way that you got the data was through, say, a manual chart review or some manual process other than automatically mining it. Seems like about maybe half of the hands are still raised. I actually expected everyone to put their hand down, so maybe you all came for the lunch, because I don't know if you're going to get a whole lot out of the first part of this. Anyway, so what's the first part, I'll just breeze through these slides because everyone already knows this. The electronic health record is really just a longitudinal view of the patient's health. It incorporates all of these different systems and technologies. And I'm using the term electronic health record, but actually probably a better title to this would be electronic medical record. So if you're an informatics purist, you'll say that the medical record is specific to the institution, so specific to Christiana, where the electronic health record would be your sum total of health-related documentation, so any provider that you've seen. Of course, it has information about your health conditions, so diagnoses, procedures, medications, but it contains a lot of other really useful information for if you're doing population health research. And you can get some information on demographics, you can get billing data, you can get information about different encounters that a patient has had with a provider, and as well from any ancillary systems, like if it's connected to a PACS, you have imaging studies, you'll have lab results, and so forth. So why do we care about this for epidemiology? And everything I'm going to talk about is within the context of observational epidemiology as opposed to, say, experimental, where you are manipulating something. This is all observational epidemiology from within the electronic health record. So really, it represents some population of patients that have received care at this institution or whichever other one. And I love slides when you put a cloud up there, because it usually means you have no idea what the hell is going on behind the scenes on it. So yeah, it's some group of people there, but we're not quite sure who they are. There's the catchment area for the hospital, right? But people will also choose to come to, say, this institution because it's well known for something, or choose not to come here. The question at the end becomes, if we do research from the electronic health record here, is that generalizable to other places, so other institutions, for example, or maybe even to the population as a whole? And the answer to that is it depends, right? Generalizability is pretty subjective. We can do a study here that I'll talk about in our NICU. Does this apply, though, to, say, the NICU at CHOP or to the NICU at McGee? The question becomes, well, how does the relationship change? How does the exposure outcome relationship may be influenced by those other NICUs? It's a subjective take. All right, so in order to kind of motivate where we're going here, I want to do some research. I have a question in mind, right? Because you have to start out with your research question. The first thing we're going to say is this answerable by data in the health record? And there's kind of two types of data I'm going to talk about here. There's the variables. So do the variables even exist? For example, if I was going to do a study that was, I don't know, how about religion and exempting from vaccine, from the annual flu vaccine we have to get? And I was going to use the data for employee health, which actually may not be a good example because I think they're paper-based records. But assume that if they're electronic, and I want to study religion, I would need a variable corresponding to someone's religion. That doesn't exist, so that's not a question we could potentially answer with the EHR. Assuming, though, that there are data or proxies for what you're looking for, the next question is, do enough patients exist for this? And that will, of course, be dictated by your power analysis. But it's also a function of, which departments are you looking at? What years are you looking at? Most likely, if anything, you'll be overpowered to do these types of analyses because there's thousands and thousands of records and interactions over the years. And you'll see when I get to the second part of this talk where I focus on the NICU that we have on the order of, I think, like 20,000 or so admissions that we used in our study. So the next part, let's say that the data exists, you know that there's the variables, you know that there's the sufficient number of patients that are available for your analysis. I want to now kind of motivate the study design that is one way of doing this. And I know that I see Pan Wu in the audience there. He gave a couple of talks previously about observational epidemiology and study design, so hopefully these slides will mesh nicely with what he's already presented. You want, though, to first of all kind of identify what's your inferential goal, what's the measures that you want as a result of this analysis, Is it just kind of a measure of what's the overall prevalence of some condition here? Are you trying to do like a risk comparison, so from one group to another? And that will begin to tell you what kind of study designs that you want, as well as what measures of time do you want? Are you just kind of taking a snapshot of everyone in the hospital today? Do you want to have some notion of temporality? So you need something. In epidemiology, we also often talk about exposures and outcomes. So you have to kind of ensure that your exposure happens before the outcome to really get at causal inference. So answering these questions will more or less dictate the types of studies that you can do. But at the end of the day, there's some core epidemiology studies, and there is all sorts of permutations to these. But again, keep in mind that I'm talking about observational epidemiology from the health record. So the easiest one we could do is just a cross section. We can go into the health record and just pull out anything, all patients, and just look for prevalence of something at some point in time. It's potentially easy to do if you have access to the data. It's cheap, it's quick, but it's really limited with what it tells you. If you want, though, to get a little bit more sophisticated about what you're doing, and specifically if you are trying to establish some risk factor as being associated with some outcome, then we really have to get into things that imply time with them. And those are mainly cohort studies, as I'll talk about them. So in a cohort, you're recruiting some population of people and you're following them over time. They're great. They're probably one of the highest quality of evidence studies you can do for observational epidemiology. They're generally expensive to do, particularly if it's a prospective study where we're starting something today and following them into the future. You also have issues to deal with about loss to follow-up, so patients don't come back over time. And then there's also case control studies, which I'm not going to really talk about here. So returning to this slide from earlier where I said that there's this cloud of people that are coming into the hospital system. That's a cohort. It's a population of people that are coming here for some care. And it's a retrospective cohort because this care has already been delivered. I'm taking today and kind of like looking back into the health record and seeing who's here. So it's retrospective, the care has occurred. And it's also something called an open cohort, which means that it's not like everyone comes here on a given day and leaves on a given day, that it changes for each patient. So they come and go at their own rate. So knowing that, we can use data from the health record to assess, say, prevalence or incidence of new conditions. Or even knowing that this is a cohort, we can sample from that cohort and do some fancy case control studies if we desire to. But what I want to do is really motivate why we're doing this as a cohort. We're trying to get an incidence measure, so the occurrence of new events over time. There's some general analytic strategies, and there's, just like with study designs, permutations, there's all sorts of permutations for how you can analyze these. But in general, when we're talking about cohort studies, we're doing this because we want to model some new conditions, so incidence. And we can look at cumulative incidence, which is so it's just a simple proportion measure. It's the number of people that have had some outcome over the total number of people at risk for that outcome. It's easy to do. It's often presented. That's just what you'll see as a percent. There's a little bit better measure called the incidence rate. It's a true rate in that we're incorporating some time element. So the numerator stays the same. It's still who has this outcome. The denominator, though, now becomes a measure of time where we say, how long have they been here at the hospital? What's the patient days that someone has contributed here? And because we're playing with the denominator, these two measures are related to each other. But think about, like, if you have cumulative incidence where we just take everyone in the denominator, we don't keep track of things like, well, how long were they actually here at the hospital for? And you can imagine that the incidence rate would differ from the cumulative incidence based on that. So if everyone experienced the event at the very beginning of their stay, it would be a different measure versus the very end of their stay. But aside from these ways of measuring incidence, we can also model them in regression equations to, as you know, control for potential confounders. And I've put on here what I think are the four most common ones out there. But by and large, you'll see people doing logistic regression for cohort studies. And personally, I may not make any fans with this. I think that's a lazy way of doing it. So you have people that experience an outcome, yes or no, great, it fits a logistic model, that's fine, and you get an odds ratio out of it. The question is how well does that odds ratio approximate the true relative risk that you're trying to get at? And then you have to be concerned with things like, well, how prevalent is the outcome? There's a handful of people out there that are advocating for using log binomial regression models, which is just a slight twist on it. And it gives you a cumulative incidence that's more or less a relative risk. You don't see a whole lot of these reported in the literature. And from my personal experience, sometimes these models are more difficult to converge than the standard logistic regression. But there's two other models that I want to talk about here, and specifically we're going to focus on the Cox model, the survival analysis, which is another way of measuring the cumulative incidence. But the nice thing about this is we can take into account the time that someone's been in the cohort. So the time until they experienced the event, or the time until they did not experience the event and they left the cohort. And so those three are all measures of cumulative incidence in some respect. If you want to model the true incidence rate, you can also do a Poisson regression, which I particularly like this one because, like I said, you do get a true measure of the rate, and it's not that difficult of a model to use. You just essentially specify cohort time as another parameter into the modeling. And the estimates you get out of that will be a rate ratio rather than the relative risk. All right, so I know that I want to do research. I know data is available. I know that some basic analytic techniques. How do I get data from the EHR? And specifically, how do I get data from PowerChart? We're all familiar with this, the front end to PowerChart here. I just took a screen grab. And let's say that I was interested in pulling out blood pressure measures for some group of people. How do I access that? And how do I do that short of manually going in for my patients and then reading this and then pulling them out? Well, one way I found to do that I particularly like is using this tool called Power Insight. Can I also get a show of hands? Like who's heard of this or used Power Insight before? Okay, cool. For that was about a quarter or so, I would say. For everyone else, it's a way to access data behind the scenes, but it gives you a nice reporting way to do it. It's a standardized, like you say, these are the variables I'm interested in, and it almost can give you just like an Excel spreadsheet view of the data. So rather than going in patient at a time doing things, you kind of design a report where you say, I'm interested in these variables, maybe on these date ranges, give me everything. If you're interested in doing more with that, Josh said he didn't mind if I mentioned his name. He's the guru behind this, and he's even running a training class. First week of February, there's still some slots available, so if you're interested in learning more about this tool, get in touch with Josh.
Are all those variables that are in PowerChart also in Power Insight?
Are the variables available in Power Insight? Yes, they are there, but getting from here to here is difficult. Because it's not like there's a variable called systolic blood pressure behind the scenes. You have to know which form to go to even ask the right question, to specify the variables the proper way into Power Insight. And that's something that Josh talks about in his class. And if you're a masochist and you like working with SQL, you can write your own queries to do this. Essentially, Power Insight is doing that for you, though. You can look behind the scenes, and to do something simple, like I went in there and I just pulled out, I think this is all nursing documentation that was in the NICU, and when I looked at the SQL code for that, it's huge. So I'd rather not do this way, but you can, and again, talk to Josh Myers if you prefer to do it. There's advantages to doing it this way, and I'll just leave it at that. So that's kind of a race, I would say, through the concepts. And now I want to spend the bulk of the time talking about the actual work that we did in the NICU. Before I do that, though, let me just take a breath here and see if there's any questions about the concepts before I move into the example. Okay. So, like I said, this example is drawn from work that I'm doing in the NICU, and I want to thank my collaborators at the beginning. So, Stephen Epps, Bailey Ingraham, David Paul, and also to Gina Moore, and I don't think Gina's here, and Josh Kessler for assistance with assembling the data. When I first started on this, obviously I was naive because I wanted to tap into the hospital systems to get all sorts of information surrounding how a baby would wind up in the NICU. So this is for inborn babies. I wanted to start out with labor, or even a mom in labor, to labor and delivery, to so risk factors while they were pregnant, to characteristics of the birth, to now what led the baby to be admitted to the NICU, as well as the discharge summary. And I met with Lynn McCone, and we kind of drew this diagram up of all the systems that data could potentially reside in. And there's a lot here, right? I would have to tap in potentially to a lot of different systems out there. And there is a data warehouse available that you can use that collates some of this, and PowerChart also collates some of this. But care in the NICU hasn't been documented in PowerChart until maybe about 10 years ago, and even still, it's only a limited set of data. More recently, there'll be more available. But I looked at this, and I kind of thought, well, this is going to be a real pain in the ass to do, until I found out about this great system called the Neonatal Information System, NIS. I'll just use that acronym. So it's this system that exists in the NICU, and it's used to generate, among other things, discharge summaries, administrative planning, QI, care improvements. It's obviously an electronic system. It's first installed in '89, but more or less captures from 1990 on 28,000 NICU admissions from 1990 till present. It's a tremendous system that's what I would probably call a clinical data repository. Again, if you're like an informatics dork like I am, you're big on the terms. So it's not really being used so much for real-time care. It's kind of documentation after the fact. And the first question that I had was, can I essentially create a retrospective cohort by interfacing with NIS? Well, I wouldn't be standing here if that was not the case. And this is my diagram of how I actually did that. And this is one of those times where I wish I can like run out there and start tracing the arrows, but I'm constricted to the podium here. Essentially what I did, though, is NIS, just like PowerChart, there's a database behind the scenes, and we can tap into that. It's a database that's managed here, in fact. It's a SQL Server database. So we can tap into that. And as much as I said earlier, I don't like writing SQL code. I wrote some SQL code to this, but it was pretty easy. What I'm doing is I use R for my statistical analysis, and that's a platform just like SAS or SPSS or Stata or whatever you like. In fact, they all can do this. They all can issue a query to a database server, and you can pull back all of these 28,000 or so admissions. I brought those into R. I do a little data cleaning, so manipulation of variables, manipulation of observations. I do some other stuff here behind the scenes. But at the end of the day, what I end up with is this export from NIS that corresponds to more or less this retrospective cohort. So it's, again, this population of babies that have been through the NICU here. And we can do, and once it's exported, I can save it in any format that I want. So I could give someone an Excel spreadsheet. I can give another researcher an SPSS data set. For my own use, I just keep it in R. And now that we established that, yeah, we can use these data to assemble a retrospective cohort, now probably the more important question, because we didn't want to just do this for the hell of it, can we use this cohort now to kind of understand outcomes in the NICU and potentially at improving health? And obviously, the success of this will be determined by you guys, I suppose. So we had a research question. The original iteration of this research question was, does census in the NICU, so the number of occupied beds, correlate with increased infections leading to sepsis? And the reason, the reason I have the scapegoat on here is I think it's just saying that the unit is really busy, just like probably with any environment. If you say that something is very busy, there's a lot going on, maybe you can use that to kind of explain why certain things happen. So we wanted to either debunk the myth that census is related to infection or uphold that. And I'll get into what occupancy actually means in a few slides. But before I do that, let me just give everyone some brief background about neonatal sepsis. And obviously, infants in the NICU are vulnerable to a variety of infections. Particularly what we are interested in is horizontal transmission, so transmission that happens within the unit, not vertical transmission that happened during labor and delivery. So we say that we're looking at late onset sepsis, or sepsis that has been diagnosed after 3 days of admission to the unit. And the risk factors are pretty well known. Younger gestation, low birth weight, low APGAR scores, and obviously invasive procedures such as being intubated or having lines inserted. But the risk is also related to care practices, including, of course, hand hygiene, disinfection, antisepsis practices. And these are often rolled into what are known as maintenance bundles. So if you're getting a line inserted, a central line, there'll be a central line maintenance bundle that describes practices surrounding that and hygiene practices. And by way of some comparison numbers, in Pediatric Infectious Disease Journal 2015, so recently, Verstrate and others calculated a crude cumulative incidence in their NICU of 6.7% for late onset sepsis, and an incidence rate of about 3.1 cases per 1,000 NICU days. So just keep those in the back of your mind when I talk about our numbers. And their population may have been a little bit a higher risk than our population, but these are just the most recent convenient numbers to kind of go into the literature and pull out. This slide right here this demonstrates what a retrospective, what the cohort looks like, kind of if you teased out each individual patient. So I went back to 1997. I mentioned earlier that that NIS goes back to 1990. The reason I went back to 97 is that's when the NICU was kind of built into its current open pod design here. So it makes sense to look at risk factors surrounding infection from that open pod design until current, and that more or less corresponds to 20 or 1,000 admissions during that period. And if you go through each, let me see if the mouse works. Can you see that? Okay, so if you go through each individual baby, they will have one of two outcomes for the purpose of this study. They will either have a diagnosis of late onset sepsis, or they will go through the study period and have what's known as right censoring. And I know on this slide I have loss to follow-up. I took this slide from something else. It's not like babies are disappearing out of the NICU and we don't know what happened to them. So loss to follow-up could happen in the study if I didn't have a discharge date and I didn't know how long that they were there for. But that didn't happen. Even out of 20,000 admissions, I knew the outcome of everyone. So I knew that they either had infection or that they went through and were discharged. When we talk about the right ways to measure census or some measure of occupancy, we also have to keep in mind that it's exposure prior to the outcome. So we don't care if there was high occupancy for this particular baby here after the outcome. And I'm speaking from experience here because I've already made this mistake, where we included everyone, or I shouldn't say we, I included all the occupancy for the entire duration of the stay. But it's really just until the event occurs or until they are discharged. And then what we have at the bottom is just a measure of the length of time. It's not their length of stay, it's the length of time that they're contributing to this cohort. Okay, let me get into a little bit more about what occupancy actually means. So it's definitely a nebulous concept here. Some people have looked at census, and there's only a handful of studies, even less than a handful, that have measured census and its relation to infection in the NICU. So census is one measure of occupancy. Census is just the number of occupied beds. But when we're talking about census, and the more you think about it, the more you realize that it's very difficult to actually measure that. For example, is it the census upon admission to the unit? And that if it was census upon admission, let's say that a baby didn't become septic until 2 weeks into the stay, then you have to consider, is there any organism that has that kind of incubation period? Probably not for the ones that we're talking about here. So census upon admission may not make the most sense. Well, what about some other measures of census? We could take, where's that slide? We can take like maybe a midpoint on census. That's another possible way to do it. What we ended up doing though was, or before I get into what we did, you can also talk about census by some threshold. So maybe if it's above 75% of what it normally is, then we call it a high census, and maybe it's that threshold effect. What we ended up doing though was kind of an area under the curve approach to this, where if you just think about how the census kind of ebbs and flows during someone's stay in the unit, we average that over the whole period. So the idea is that the higher the average census during their length of stay, or the length of time in the cohort, maybe that is the best measure of this census effect. The other measure that we had in terms of occupancy, so census is just, it's what it is. It's the number of occupied beds. It doesn't really define how busy the unit is, and maybe that's what we're actually getting at here, is that we need some measure of the acuity of the unit. We need a proxy for that. One way to model this kind of demands on the unit is to have a proxy for acuity, and we hypothesized that one way we could do that is through the proportion of very preterm infants. So these would be babies born at less than 32 weeks of gestation. The idea here is that we measured this like we did with census, in that we averaged it over the length of time that they're contributing, that they're in the cohort. And we're saying that, all right, independent of the census in the unit, maybe it's the proportion of very preterm kids there that's putting increased demands on the unit, and that's why maybe we'll see some increased infections. We have these, so at the end of the day, we have these two competing measures of occupancy. Census and proportion of very preterm infants. The outcome, as I mentioned, is lab confirmed isolation of an organism for late onset sepsis. We broke these into 8 categories, and we did this just based on the proportion that we would expect of these organisms based on other literature out there. So we had categories for Staph aureus, and we further categorized that by methicillin sensitive or resistant. We had a category for E. coli, for group B strep, and for coagulase negative staph. And that really encompasses the majority of the organisms that you'll see leading to infections. Then we had some just catch-all categories for gram-positive and gram-negative bacteria. And we also include candida fungal infections on there. These are all, I probably should have said this, these are all bacterial or fungal. We did not consider viral causes. And we also had just one, we had a category for other, so this could be in either it wasn't identified or it was a polymicrobial infection. For the analysis on this, so now we know what the exposure is, its occupancy, we know what the outcome is, its incident late onset sepsis. For the analysis, I wanted to use, with Bailey's assistance, Cox proportional hazards modeling. And this is, so these were some methods pioneered by Sir David Cox, who's still kicking, I found out. He's in his 90s, he's over in England. And the reason that we wanted to use Cox proportional modeling to do this is it has some nice features. It takes into account the time to the event, so the time to when they were diagnosed with the infection. It takes into account the follow-up time. And one of the things we particularly wanted to check for is this notion of a time-varying exposure, so the occupancy varying over the cohort time. The estimates that these models produce are pretty intuitive to understand, and they can be thought of as cumulative incidence relative risks. Maybe the flip side to this is doing this modeling is a bit more challenging in that there's more assumptions you need to meet. Aside from the typical regression assumptions, independence of observation and for in a cohort, the independence of follow-up or independence of censoring and survival. We also have to make sure the proportional hazards over time, so just the hazard ratio stays constant over the study period. And with Bailey's assistance, ran these models, and all the assumptions were met, and we have some estimates. During the study period, again, 1997-2014, roughly 20,000 admissions. We had 446 cases of late onset sepsis. The cumulative incidence was 2.3%, and the incidence rate was 3.1 cases per 1,000 NICU days at the study inception, so that would be this guy over here. And that decreased during follow-up to a half a case per 1,000 NICU days, so over here. And you can readily see that from this graph here, which just shows the steady decline over time. And we attributed that to care improvement at the hospital and implementation of maintenance bundles and just general focus on hand hygiene. Some other notable aspects to the distribution of cases over time is that you can see that the majority of cases really are caused by coagulase negative staph, followed by Staph aureus and GBS. And in terms of Staph aureus, we had some more cases of MRSA in the early 2000s and just real sporadic cases since then. That's not actually shown on this graph. That's another graph I have. The proportion, though, of the organisms has stayed more or less consistent over time. So even though the number of... What did I do? So even though the number of cases has declined over time, the proportion of organisms contributing to those cases has more or less remained consistent. All right, and so now let's get to the measures of occupancy that we have here. And I'll focus on the two initially, and then I'll talk about the other stuff here. So average census during the stay, hazard ratio 1.01. It crossed 1 in the confidence interval. So we can say that given the data, we don't really see an association between average census and increased risk and change in risk for late onset sepsis. But we do have something interesting here in that when we looked at the proportion of very preterm infants in the unit, we see that there is this small but still interesting uptick in infection. So it's this 2% increased risk of infection, and you may say, well, that's super small and minimal. Is that actually anything meaningful? But what I would respond to that with is keep in mind that the way that this measure is interpreted is that this is 2% for each percent increase in very preterm infants in the unit. So if you had two infants that were all other things considered equal, one admitted during, or one that was in the NICU during the time of, say, 30% average proportion of very preterm versus an infant that was in the unit during like a 60% average proportion. That's actually a 60% increase in risk. So a meaningful increase in risk there based on the proportion. We had some other associations here that we saw that were consistent with the literature out there, and that's an increase in risk for Black non-Hispanic infants, an increase in risk for Hispanic infants relative to non-Black non-Hispanic. And as expected, we saw that if the infant was born preterm, they have an increased risk, and especially if they're intubated, right, they have a very strong risk increase associated with the late onset sepsis. And we also observed perhaps some seasonality here. We noted some trends here. So relative to winter, it appeared that the warmer months may have an association with increased infections. And that kind of I think it makes a little bit of sense. When I looked into what other people have reported about this, you tend to see certain bacterial organisms lead to more infections during warmer months. And this is different from certain viral organisms that seem to peak in incidence during the colder months, during the winter months. What does this all mean? So we can say that perhaps that it's not census in and of itself. It's not the number of occupied beds, but perhaps it is what's the acuity of the unit. And again, the way we measured that was proportion of very preterm infants. But this is still a proxy for the true exposure. This is just a risk factor, and we don't have a direct measure of what that may be. We don't have a direct measure of the acuity of the unit, say by using SNAP or crib scores. We didn't have that. And this also gets at what is happening behind the scenes. Is this a change in visitation? Is it a change in care based on time constraints? Or is it just some alteration of hygiene practices? We can't directly talk about that through these proxy measures. As well, going back to what I said at the beginning of the talk, how generalizable are these findings to other NICUs? Yeah, our NICU may differ from other NICUs, but the question we have to ask is, do other NICUs change their care practices based on either occupancy or acuity of the unit? If they don't, these findings are probably generalizable. If they do, then they may need to revisit that, particularly to those places. Some strengths to this work is it's a great population that it's very there's a lot of data there, and it's been validated by nursing staff. It's all coded. I really didn't have to do a whole lot with it. And it's a large population that, if anything, we are overpowered to detect certain differences. And that wraps up what I wanted to talk about for the main study here. I want to talk just for a moment, though, about future directions for this data set. Because as I mentioned, it's from NIS, which is this standalone system that we have in the pediatric department. But what we want to do is we want to tap it into PowerChart, and we can connect to it and just bring in some additional data, some, say, maternal history that we don't have right now in NIS. One of the things I'm particularly interested in, though, is modeling infection in the NICU. And I don't know how many of you went to that talk at the end of last year as part of this series on network and graph modeling. That talk was perfectly timed because I was working on the same thing at the time. And I love, this is like, for me, I love, it's when two reality shows meet each other, you know, like the Top Chef judge is all of a sudden on Project Runway getting a makeover, something stupid like that. This is this talk meeting this other talk about network theory. What we're doing here is we're connecting our NIS data to PowerChart to look at encounters that the healthcare teams that take care of the babies. And I've made this model here it's attempting to simulate the average day in the NICU. Each red node on here would be a baby. And all these lines here are connecting babies together based on the teams of providers that have interacted with that baby and then went on to interact with other babies. we're going to try and use this to model infection in the NICU. I'm not going to give any additional info at this time about this. And lastly, while I have your attention, thank you for mentioning the blog URL. If you are a nerd like me and if you want to read about more of these methodologic issues, I blog about them on my website here. And that's all I had. So it looks like we have 10 minutes left. I'm happy to take any questions.
So Neal, you talked about occupancy and acuity. What if the correlation was if there's a sentinel case already existent in the NICU? Since we're worried about horizontal transmission, what if the only correlation is there's a single case already present? And that's really what raises the risk. How do you account for that?
That is a fantastic question, something we actually considered. Ideally, hygiene practices, right, would prevent one case from being transmitted to the other. One way we started to do this, and that's a limitation of the current modeling, but we started to explore, with Bailey's assistance, this notion of, it's called a mixed effects Cox model, and what we do is we are attempting to account for the fact that there's already a baby present in the unit that is sick, and maybe that's what's resulting in the increased risk for infection. We started down that path, didn't finish it because it's particularly challenging to say, all right, what do we want to say is the overlapping period? Is it the entire duration of the stay? Is it something surrounding the incubation period of that organism? So to respond to that, I would say, fantastic question, work in progress, stay tuned. That could be part 2 where we model that.
And the proximity of the
yeah.
infection to where that sentinel case exists.
100%. And when I started doing this network modeling here, the way that the graph is drawn right now, it's just like blam, everyone's there and it's completely random in the unit. But ideally, we would have the bed side and or the bed number, and we would be able to map that to where they are. Unfortunately, as the data are recorded right now in PowerChart, it is just it's essentially where they were discharged from the bed. I don't have that electronic capture of if they move beds or anything, but I would like to get there.
Good stuff.
Yeah.
What's the proportion of babies who stay more than 72 hours in the NICU?
The proportion of babies that stay more than 72 hours in the NICU. I do not know the answer to that. Dr. Epps, would you know the answer?
Ursula?
Oh. I don't know. Off the top of my head, I can tell
Way
you.
over half, right? It's the majority, though, is it not?
Oh, is it?
Yeah.
Because that could be also, that seems to be an important risk factor to consider. Because, the babies who would just leave early are not at risk, or they are not exposed to.
Correct. The modeling that we did, though, should take into account the duration of their stay in the NICU. Any additional questions? All right, great. Thanks, everyone, for your time.